We're muted. There it goes.
Good afternoon, everyone, and welcome to the Children's Behavioral Health Working Group. We're really excited to kick this off today, and we know that many others will be joining throughout the time, but we're going to go ahead and get started. We have a lot to cover in our hour. So my name is Ann Jensen. I am the Innovations Officer for Nevada Medicaid, and I'm now going to call this meeting to order. So as a reminder, this is our kickoff conversation. Really excited to spend time getting to know our representatives today, as well as sharing a bit more about the vision of our work, and look forward to your engagement throughout this hour. So with that, I will turn it over to Stacy Weeks, our administrator. She is going to introduce our Nevada Medicaid team, and she will then turn it over to each of our representatives to introduce themselves, and we'll ensure that we have a quorum of members present at that time. So Stacy, I'll turn it over to you.
Great. Thanks, Anne. Hi, everyone. Happy is it Wednesday finally? I think, yes. I'm Stacy Weeks. I'm the administrator at the Division of Healthcare Financing and Policy, also often called Nevada Medicaid. I also have with us today our team, Dr. Melinda Southard. I don't know if Melinda can come off camera and just say hi. Melinda oversees our stakeholdering group and community engagement. Melinda, I don't know if you're on. Am I not seeing you yet?
Hello, I am here.
Okay, good. Yay.
Hi, everybody.
There's Melinda. Hi, thanks, Melinda. We also have with us Teresa Karsten. I don't know if Teresa, if you're on yet, if you want to say hi and just tell people what you're over. Maybe she hasn't quite joined. Teresa is over our managed care program, as well as is everyone else hearing that, Anne, the unknown participant thing? Okay.
Yeah, we're working to get that turned off.
Okay, it's all right. I get distracted. Teresa is she oversees managed care, also our benefits program, and a lot of other areas of the division and Medicaid. And then we have Dr. Rashonda Clemens, our medical officer. Dr. Clemens, if you're on, you want to say hi? Okay. And then Sarah Dearborn, who is our benefits chief. I don't know if Sarah's on yet, but if she wants to say hi to everyone.
Hi, everyone.
Thanks, Sarah. Sarah's over our medical and our behavioral health benefits as well. I think it's dental as well. So she oversees that area. Ann Jensen, you just met, was our innovations officer. And we also have with us Matt Burdick. He's a new member of our team. He's a behavioral health policy expert we have hired on contract to support this work. I don't know, Matt, if you have a second to say hello.
Yep. Hi, everyone. Great to see everyone here.
Thanks, Matt. All right. And then we're also going to be working with our sister agencies at the department and here soon to put together sort of our plan internally, but also to bring in staff to this meeting. And so we'll have other sister agencies who are assigned to this group and to be support to the committee, as well as just answering questions for the public as we move forward. Next slide, please. All right, so why are we all here? So just a quick overview, and I know Anne put this in some of her announcement materials around this work group, but just to kind of just ground us all here today is that really the purpose of this working group is to really offer specific advice, expert opinions, suggestions to our state team regarding the project that we are all embarking on for children's behavioral health. We're also looking for clinical and programmatic input and lived experience feedback on key components of our new and enhanced services in Medicaid. And we're also looking for this group and also public feedback on policy development. So when we say policy, I'm talking about benefits and payment structures and coverage, and also the delivery system that we're going to be building. And that's what I just mentioned there, is that just giving us that feedback as we move forward with a lot of these changes. And as you can see, we have a very diverse work group. We pulled from both youth and families with lived experience that are here today with us. We have association and service provider representation, as well as different experts and people with experience in working in this field and with children's behavioral health. We also have state and local system partners on this working group, as well as rural and urban representation. All right, Anne, I think it's you.
Yeah, thanks, Stacy. So I'm really excited for our representatives to introduce themselves and to kind of share their affiliation or what brings them to the group. So we're going to go through this list. There are a total of 29 selected representatives. So appreciate everyone's patience. I think it's really important for all of us to get to know each other and know a little bit more about who will be serving this important role on our representative group. So Matt, are you here?
Which Matt? Me?
Matt Lehman, yes.
Okay, yes.
Yes, I'm here. I'm the parent of a high needs foster kid. I'm also a behavioral health provider, and I also work with one of the foster care judges who also runs the detention alternative for autistic youth and youth who have fetal alcohol spectrum issues. So kind of lots of different multiple connections here.
Yeah, wonderful. We're glad you're a part of it. Thank you, Matt.
No problem.
Leah Skinner, you here?
I am. Hi, everyone. I'm Leah Skinner. I am the parent of a 16-year-old female who has been in and out of mental health facilities and then also had some mental health episodes for the last 7 years. Previous to that, she has been in many different programs as far as Nevada Early Interventions, the Teddy program down in Douglas County. So different programs and different aspects throughout the state of Nevada. And so I'm just looking to help others if I'm able to. And I'm really excited to be a part of this group. So thank you for having me.
Thank you for sharing, Leah. We're glad you're here. And Lanisha. Lanisha, are you here? Maybe she's still joining. Okay, we'll give her a few minutes and we'll circle back. JD.
Hi, my name's JD. I'm in Mineral County, Nevada, so I'm a rural. I am actually fostering to adopt a kid out of Washoe County that came from behavioral treatment centers. So I'm looking forward to see what we could do to maybe enhance benefits and services for these kids.
Wonderful. Thank you, JD. We're glad you're here. And for our youth representatives, Devin, are you here? I think I saw Devin call in, so maybe he's having trouble getting off mute, but we'll come back. How about Annalicia? Okay, Devin and Annalicia we'll circle back, but we're looking forward to having you as part of this group. And lastly, Luke.
Hello, good afternoon. My name is Luke Dumoran, and I am a self-advocate. Excited to be a part of the working group to provide my perspective and experience, and hopefully to build a better system for the individuals we serve.
Wonderful. Thank you, Luke. We're glad to have you. And with that, we will move to our first group of behavioral health provider representatives. And for everyone here, I appreciate your patience as I learn your names. Please do correct me if I mispronounce your name. I want to make sure I get it right. So Alana. Alana.
Hello.
Yeah, say Alana.
Yeah. Hi. So my name is Alana Rogney. I am the medical director at Rural Nevada Counseling, and we are a CCBHC. And I'm also a parent. My husband and I are raising 3 of his grandchildren, and I have kids of my own. So this is a really big opportunity for us.
Wonderful. We're glad to have you. Thank you. And Dave.
Good afternoon, everyone. Dave Doyle with Director of Eagle Nevada. Also an active member of.
I'm having trouble hearing Dave. Is that just me?
No, Dave's cutting out.
No, he's very quiet.
Dave, can you hear us?
Yeah.
Oh, it's still pretty quiet.
No. Go ahead. I guess I'm having problems with my mic. I'll defer and I'll introduce later. I'm so sorry.
No worries. That sounded a lot better though. So we'll come back to you at the end, but I know Teams doesn't always play nice. So thanks for your patience. Dr. McGrew.
Hi, I'm Megan McGrew. I am the owner and CEO of Impact ABA Services. We offer assent-based, neurodiversity affirming, trauma assumed care. So applied behavior analysis primarily, but in the last couple of years, we've also been offering behavioral consultative support, and increasingly we're working with a lot of foster cases to provide that support across a whole range of diagnoses and needs. So I'm so excited that the state is making big moves to improve that system, because anything we can do to help these kids is really important.
Wonderful. Thank you. We're glad you're part of it. Dr. Freeman.
Dr. Megan Freeman. I'm a licensed psychologist and I oversee mental health services at the Boys and Girls Clubs of Southern Nevada. So I have a team of 6 licensed providers in addition to myself, and 14 students this semester from bachelor's, master's, and doctoral behavioral health programs. And we provide services directly in the clubhouses. There's 13 clubhouses in Southern Nevada. And really excited to be a part of this group. We see many families who are Medicaid recipients, and really love to see the direction moving towards more home and community-based services, and excited to contribute from that perspective.
Wonderful. Thank you for all you're doing. And Dr. Cooper.
Hi there, I'm Takesha Cooper. I'm a pediatric psychiatrist. I'm also the chair of psychiatry, the Department of Psychiatry at UNR Med, and the chief of behavioral health for Renown Health. I am a parent as well of a child who's had mental health struggles. And so this is near and dear to my heart, and I'm passionate about providing really high quality care, compassionate care to kids. So delighted to be on this group and so happy to see people. The diversity is great, and I love having people with lived experience because their voice is paramount. So thanks for having me.
Thank you, Dr. Cooper. Wonderful. Glenda? Glenda, are you on? All right, so we'll come back to Glenda. Natalie?
I just turned it on. I'm here, by the way, Glenda. Sorry, my mic was muted. Just
No
to let you know.
worries. No worries. Welcome, Glenda. Do you want to introduce yourself?
Sure. I'm Glenda Cruz Juarez. I'm actually an LCSW currently at Viridian Wellness. My background has been also in child welfare. I was a CPS investigator as well as a permanency worker. And I currently work with mostly teens and young adults, but mostly teens with high mental health needs, as well as being on the spectrum. But I also work with Spanish-speaking families. So that's another side that I do individual and family therapy.
Wonderful. We're really glad to have you, Glenda. Thanks for being here.
Thank you.
Wonderful. Natalie?
Hi, I'm Natalie Sanchez. I'm one of the owners and the clinical director at Health Psychology Associates. So I oversee our mental health programs. We have, I think, currently 36 folks on our team providing therapy. We are big into supporting Medicaid. That is a passion of mine since I've been an intern, and I'm just really excited to be on this group and hope to continue to support, good quality care and equity and socially diverse treatment.
Wonderful. Thanks, Natalie. Stephanie, are you on? Okay. I don't see Stephanie's name on our list, so we'll come back. Janelle from Carson Tahoe.
Hi there, my name's Janelle Hoover. I am the Chief Nursing Officer at Carson Tahoe Health. I also oversee our behavioral health services. I also am the mom of 5 kids, and my husband and I just recently fostered a child who has some pretty severe mental health needs. And so we have him at our home and, are just navigating this new world that we're living in from a totally different side. So I'm happy to be here and be part of the group.
Wonderful. Thank you, Janelle. We're glad to have you. Wonderful. So our community partner representatives. Angie, are you here? I think I saw Angie's name on our list. I think she joined earlier, so maybe she's having trouble getting off of you. Angie, we can come back to you. Oh, I see you come off me now. Can you hear us?
Yeah, sorry. Can you hear me okay?
Yes, we can. No worries.
Okay, great. Thanks. I'm so appreciative of being able to be on the work group and look forward to working with all of you. I'm the director for the Reno Sparks Tribal Health Center and really happy to be joining in just for a voice on the tribal side. So really appreciate the collaborative effort. Thank you so much.
Yeah, we're glad to have you here. Thanks, Angie. Nikki, are you on? Okay, we'll come back to Nikki, but we're looking forward to having her represent our rural health centers on the tribal health side as well. Gwyneth, on the juvenile justice side, are you here?
Good afternoon, everybody. I'm Gwyneth Smith. I am a Chief Deputy District Attorney down here in Clark County. I have a number of duties at the Clark County DA's office that have kind of brought me into the realm of youth, mental, and behavioral health. I'm the DA assigned to what we call the mental health court calendar. So these are all of the cases involving children in foster care who are acutely or residentially hospitalized. I'm also the DA on what we call the dually involved youth calendar. Those are youth involved in both the juvenile dependency and delinquency systems. And both of those populations present with a really high level of need for services. And so in that capacity, I've been working with a number of different people on this call. I've already seen some familiar faces. I'm very excited and grateful for the attention that Nevada Medicaid is giving this effort, and I'm really grateful also to be a part of it. So I look forward to working with everyone. Thank you.
Thank you so much. Jessica, are you here?
I am. Hi, everybody. Jessica Gogachia. I am a marriage and family therapist, and I am a coordinator at Human Services Agency. I oversee multiple different program areas, but I think probably for the purpose of being on this work group, I am the coordinator over our Children's Mobile Crisis Response Team, which as of July 1st moved from DCFS, the Washoe County version and portion of Children's Mobile Crisis to Washoe County. And I'm the coordinator of that program. And then previously, prior to coming to the county, I ran Medicaid day treatment programs and have just a history as a marriage and family therapist and a lot of history with Medicaid. And like Natalie, I'm a big Medicaid advocate. And so I'm really looking forward to this work group.
Wonderful. We're glad to have you, Jessica. Miambi.
Good afternoon, everyone. I am Miambi Newburn Johnson. I am a licensed clinical social worker, and I've worked with Clark County Family Services for many years, about 17 years now. For the purposes of this working group, I'm happy to join in and really share the perspective at the many years of experience. We have so many experiences of youth becoming system involved and being relinquished into care as a result of unmet mental health needs and behavioral health needs. So I'm happy to weigh in on that and those experiences. I also have experience just as a clinical social worker in providing mental health services to Medicaid recipients in the community. So I'm just happy to be a part of the conversation and a part of the solution moving forward. So thank you for having me.
Wonderful. We're really glad to have you. Shayla let me know that she is out of the office this week, so she was unable to attend, but looks forward to meeting you all, and we will introduce her at our next meeting as well. And last but not least, we'll end with our final community partners. Bree.
Yeah, hello everyone. My name's Bree Taylor, and I'm currently the Integrative Health Services Coordinator with Humboldt County School District. And prior to taking this position, I worked for the Department of Education as the School Health Services and Medicaid Coordinator. I'm also a registered nurse, and it's an honor to be part of this work group. Thank you.
Thank you, Bree. And Karen.
Good afternoon. My name is Karen Tacher, and I am the Executive Director of Nevada PEP, which is a statewide advocacy organization for families who have children with disabilities and mental health issues. I am the parent of two young men that have lived experience, and what I'm looking forward to working on this committee as we've been working many years on improving children's mental health services in Nevada. And I think this is the biggest effort that we've undergone, and I'm excited to be a part of the solution. I'm also part of the Clark County Children's Mental Health Consortium.
Wonderful. We're really glad to have you, Karen. Thank you. And Robin.
Hi, I'm Robin Reedy. I'm the Executive Director of the National Alliance on Mental Illness here in Nevada. It's a statewide organization. We advocate, we educate, and we support people who live with a mental health condition and the family and friends that love them. I echo Karen's comments about working very hard to make changes throughout the state, and am excited to see this going forward. And I am a mother and a grandmother and a great grandmother, and I believe almost everyone has something going on in their mental health. So there you go.
We're really glad to have you, Robin. Thank you. And Jonathan.
Hey, thank you so much. Jonathan Norman, I'm with the Nevada Coalition of Legal Service Providers, which pertinent for this call is Legal Aid Center and Northern Nevada Legal Aid, who both provide direct representation to kids in foster care. When I first came to Nevada, that was my job at Legal Aid Center. I was a CAP attorney doing direct representation, so familiar with the needs of our foster kids. Thanks.
Wonderful. Thank you, Jonathan. Last but not least, Santosha.
Hi everyone, I'm Santosha.
Wonderful. I believe you just joined. We're just introducing ourselves and sharing where we're coming from for this working group.
Thank you. Nice to meet you all. Sorry for the late join. I was stuck in traffic. But I'm Santosha. I'm a fourth-year medical student at UNLV Med School here. I'm also the mental health liaison of the American Academy of Pediatrics Nevada chapter. So excited to start working on stuff for behavioral health and kids and families in the Valley. Yeah, I'm excited to be here.
Wonderful. We're glad to have you, and no worries at all. I would like to go back to anyone who we may not have gotten a chance to introduce themselves earlier, in any other representatives that have not yet introduced themselves. Dave, do we have you?
Can you hear me any better now, Anne, or is it still muffled?
It's a little bit better. We'll listen hard.
Okay,
No
please
worries.
excuse my shouting if I am. Guys, good afternoon. Dave Doyle with Eagle Quest, representing specialized foster care and therapeutic specialized foster care providers. Truly excited to be part of. Also bring about 20 years experience with FFTA, the Family Focused Treatment Association, trying to bring best practice to foster care, and just want to make sure our kids have good accessibility and that there's no unanticipated consequences that we all work with. Thank you so much.
Wonderful. Thank you, Dave. And for those that couldn't hear, Dave is representing EcoQuest, which is this current specialized foster care provider with us. So really important perspective for this group. All right, with that, we'll move forward. If there's any other representatives that do join later, please just let me know over Teams and we'll be excited to introduce you. We have reached quorum, so with that, we will move forward. I have some brief operational items to update the group on, and then I'll turn it over to Stacy to really give a good overview of our Medicaid transformation and our visions of this work. So, as you can tell, open meeting law will apply to this forum. It's really important that all members of the public are able to listen and contribute in this forum. So our DHCFP meetings page will have a notification of all meetings. We will also send notification to our behavioral health listserv. So if you are not on that listserv or you're not sure if you're on the listserv, we'll share an email address at the end for you to reach out to us and make sure that you're included. While this is an open meeting law forum, we also do want to make this as discussion-based as possible. So representatives are encouraged to raise their hand at any point with questions or input. We ask that you join with your camera on as you're able. We really appreciate everything we can do to make this virtual environment feel as collaborative as possible. We will have an opportunity for public comment after each of our discussion items, as well as at the end of our forum. So we welcome members of the public to submit their input and feedback at that time as well. And lastly, representatives, we shared our availability form when you were selected. Encourage you to please submit that by the end of this week. I will resend that over email tomorrow morning. So if you are not remembering that, I'm happy to resend. We want to make sure this time works. We have a range of folks with a lot of different schedules we're trying to wrangle, and we want to find a time that works best. So our November and December meetings will be scheduled based off of this availability form. So we really appreciate you taking the time to fill that out. So with that, I will turn it over to Stacy for our transformation overview.
Thank you, Anne. So first of all, I just want to say I'm super happy to have it that all of you came today because it's just great to have everyone here and just want you guys to feel like this is also a conversation. I don't want us just to be talking at you. But it will feel like that for a minute. So just bear with us. And I think in future meetings, we want it to be more of a conversation as we go forward. But a lot of this is just laying the background and foundation for why we're here and, and how we're going to make the most of it together and try to get some real reforms done. So the reason, kind of what spearheaded a lot of this work, kind of pushed it forward, I think, on a faster trajectory is really the Department of Justice came in, it's about 2 years ago now, and found that Nevada was out of compliance with the Americans with Disabilities Act for children with behavioral health disabilities. And the reason for that is under the ADA and the Olmstead case that was passed, or the case that happened many, many years ago, has really been used across the country, but to help children with behavioral health needs. But really, they found that we don't have the community supports needed. So children with behavioral health disabilities can stay living in their community with their family or their foster care family in a way that they thrive. Really, children in Nevada really just have this inpatient or residential institutional care available to them. And so the DOJ is, we're in the middle of negotiations and a settlement agreement. Hopefully soon that will be done and we can talk more in detail about what's in that agreement. But really, we are looking at trying our best to find ways to support children in the community so they do not end up going out of state for residential treatment or even going into even in-state residential treatment. That should really be the last option on the table. We really want children to remain and be thriving in their home and in school and with their family. Next slide, please. So when we first started out on this vision, we kind of set this out for some of our earlier public workshops, but our vision really is that Nevada children have access to the behavioral health services they need to live and thrive with their families and in their communities. Our values around this have been, we want this to be child-centered, family-focused, community-based, and accountable. I think a big piece of it often we find is everyone's pointing fingers sometimes, like who's responsible for what and who's doing what. And so one of the things that we want to do very clear is lay out for families what the options are and who's accountable for it. And so they know how to hold people accountable for getting the services they need. Also, a big piece of this is ensuring that we're coordinated. Luckily, we have very helpful and engaging sister agency partners that I think, we are going to be coordinated in that way, but also with our local partners. So Clark County, Washoe, and others that we work with on a regular basis, ensuring that we are coordinated. So that's a big piece of what we think we need to do better, obviously, for children. Next slide. So I just wanted to kind of, let's just ground us first in the continuum, right? So this is really the recommended continuum nationally for, if we think about, if we had a continuum in Nevada, this is what we'd have. We'd have these 4 buckets of services. The first one here on the left side is early identification intervention. So really, any door that the child enters into, like a provider setting, healthcare provider, school setting, even if they come in contact with the county or the state, they are being screened and identified early for behavioral health services. And so that we are really getting upstream. We know that that is more effective in treating and ensuring children can remain in their communities. And that really is a low intensity service, which means it's cost effective overall, right? This is really low hanging fruit that we need to do better in Nevada on. So that's a big piece that right now we really lack some of that work. The next piece here is outpatient and community treatment. This is the piece I think we know in Medicaid. We don't cover enough of this broadly for everyone. And so that's a big piece of what we're adding to the table. And we're going to start implementing those pieces soon. And then the third bucket is that crisis response and stabilization, ensuring that a family can access response and get crisis stabilization and mobile crisis if needed. And the last but not least is that higher intensity service that's costly, and is also institutionalizing, in many ways for children, is that residential and inpatient psych hospital treatment. Sometimes that is necessary, but we really want that to not be as necessary for every child that has services or is in need of service. Next slide, please. So when we look at our current capacity in Nevada, on the left side here, we really have our biggest and truly is really where we see the most service going out the door is residential inpatient. And that's one of the reasons the DOJ is knocking on our door, right? And rightly so. We really want to be on this right side here, where we have kids getting identified early, that not only are they identified, but they're connected to services, right? And that's going to be really important. And that's where that outpatient community-based service bubble, we need it big and we need it available statewide. And then crisis response and stabilization, there's a lot of work going into this. It's not just Medicaid. There are a lot of different partners, counties, as well as state partners working on this. But as we grow this piece is really going to be crucial to this entire continuum. And then ensuring that we have the stabilization services available. And then residential treatment, it will not go away. We know that. There are some children that are still going to need to go to a residential setting, but it should not be forever. And same with inpatient psych. It is needed, but it needs to be appropriate, right? And that we are trying our best to ensure children are avoiding that scenario as much as we can. Next slide, please. So in putting together and thinking through what does Nevada need to do to move forward, you know, for statewide, for all children that need these services, we really recognize that Medicaid is a big payer in the state and is the one tool that the state has to really drive system change. And we know today we aren't covering enough of services. And this is the new package that we want all children that need these services to have available to them and their families and to foster care families. So it would be your wraparound services, family, youth, and peer supports, individual and family therapies, psychosocial rehab services, plan and emergency respite care for caregivers and family and parents. And then always making sure that these families know that these services that are community services are covered if they have a child who has a behavioral health need, that they can get transportation, that they can get mobile crisis, they know how to find crisis stabilization, that medication management, they know where to find it and who to call, right? Psychiatric care, day treatment, intensive outpatient, partial hospitalization, as well as youth employment supports, which is something we really want to support as our youth are getting older, that they're able to transition into adulthood and be successful. Because, you know, mental illness does not end. It continues to grow with many of these populations. So we want to make sure people have the tools that they need to be successful as they grow and go into the job market, college, wherever is next for them. And so this here, all these pieces are a big piece of what we want to bring to this table. I just want to note that this package is not in silo of the medical benefit that we also cover in Medicaid. So when we think about what we're covering for children, we know that the evidence shows that these benefits need to be integrated into the entire healthcare benefit package. That behavioral health is in parity, right, with physical health. So I just want to note that this here is a special package that is tied to a family and a child who has a behavioral health need, that they still have their other services as well. Next slide, please. So I apologize. I know this is a lot to absorb, but I just kind of wanted for everyone to see where we are now, what we're trying to add, and what we're trying to improve. So when we look at that continuum here, right, you've got on the left again, the identification, right? We've got outpatient services, crisis response, and inpatient residential. So this is the behavioral health continuum and coverage that we really want to have. And the light colored there is the new or expanded service array that we are adding in Medicaid over the next 6 to 12 months. It's going to take us time. Unfortunately, in Medicaid, we get the money and then we have to go through quite a process. And part of that process is working with all of you to make sure we get it right. So when we do open and create a service, that people can access it and providers can bill us and pay, and we can pay them for it. So wraparound is a new service to Medicaid. Intensive care management and care coordination is part of that service. Peer supports and services for youth and family. That is a new service in Medicaid that should be coming online sooner than later. Respite care is brand new, and often it is not something we typically cover in Medicaid. So we're looking at special authorities on how to cover this service. Intensive targeted case and care management services. We do cover case management, but really that intensive focused service, not just for children in foster care, that is for all children that fall into the eligibility category for this program. And then all the gray things that you see here are the areas we know we need to do better in payment. Medicaid often is the lowest payer. It's a public taxpayer funded program. What we get paid from the legislature is how we base our rates. We don't always base them on, if we could pay market rate, we would, but we have to use the money we're given. So we did get new money last session through the private hospital tax. which is going to give us over the next biennium with federal funds, new money to put into Medicaid covered services. And it's about 200 million in total. And that's a lot of money. I know that sounds like a lot, but these services are costly. And if we're doing it well, we will use all of that money, right? Residential treatment is one area. We are increasing the daily rate. It will no longer be cost-based. It will be a fair market rate at $800, and there will be bonus payments tied to quality. Because here's the other thing. We want to make sure children that are going into these centers are actually successful in this setting, that they're not there forever. They're getting out in a good amount of time that we think is reasonable, and that they're successful in their community. They're not coming back, right? The recidivism rate is low. We're also looking for ensuring that children are not, we're not seeing those outcomes that you would see if a child was not transitioning well, right? That they're having more crisis events, those types of things. Intensive in-home supports is also another one. We're increasing the rate, psychosocial rehab, individual family therapies, inpatient hospital psych. We're increasing the rates there as well. And the last but not least, these are existing services. And I will say, for those of you that may have seen our agency request, we are asking that many of these areas see rate increases next session with that provider tax money. So that 200 million will be using a lot of that here to increase rates for all of these services here that you can see. I think that's it. Next slide. All right, sorry, I feel like it's a lot, Anne, and I'm sorry I added all of this for everyone. But the other piece is we can cover services all day. Doesn't mean people are going to get access to them, right? There's a workforce component to that, but there's also a delivery system component to that. We have to ensure that we are ensuring that children are being connected to these services, that families are getting these services, and we can hold someone accountable for that. Right. And I will say at the state level, that is really hard to operate. It's really like a managed care plan. Oh, thanks. See the happiness. So how do we do that? Right. And I'm not going to say, I will admit every day managed care is not perfect, but it is better than what we have in fee for service. Right now, we do not have the true ability to see and track and look at quality and pay for it the way we need to. And, we're still talking about what kind of managed care structure do we want? Do we want it really to look like the managed care plans we have today, or do we want it to be a little dialed back and more of a hybrid? So I just want to throw that out there, that there's some opportunity here for us to work on this, but we have to do better than fee for service today because we are not managing the care for this population. So it's going to be an integrated benefit. And so whatever entity we create to really manage the service in the provider network, we'll have to ensure that the medical services are included, that they have the behavioral health care package I just showed you, and all the behavioral health services we cover in Medicaid, transportation, as well as intensive care and case management. We're going to be releasing an RFI soon, a request for information for public feedback, and we want to bring that feedback to this group to help us inform the design of this new system. We're going to ensure that this new entity has to have network adequacy standards. We don't have that in fee for service today. I couldn't tell you if we had an adequate network because we don't have to do that in fee for service. But in this system, we will. We have to have value added services. We will be asking for value added services around employment and housing supports for this population, as well as meals. We know that the social determinants of health matter, that, it's not just healthcare. All these other pieces matter to a child's life. So these are things that we'll be asking this entity to pay with their profits to cover. Collaboration agreements with schools, child welfare, courts, and other partners, 24-hour family nurse support line, quality incentives and performance monitoring that we can put publicly and post, and we will transparently be sharing that with this group as well as publicly on our website. We also have something in Nevada that we do in managed care is called community reinvestment. We'll be requiring this plan to reinvest a portion of their profits into workforce development as well as community supports for families and children and foster care families. Next slide, please. And just before I turn it over to Anne, that doesn't go live for a while, so no worries. That's January 1, 2027. So we have time to build it, but the procurement process does take about a year. So we want to spend the next 6 to 9 months with you all working on this, and as well as our county partners. All right, Anne, I'm going to turn it over to you. And should we stop for questions? I don't know if that's helpful for more of a discussion.
Yes. We
Any
have
questions? Yeah.
Yeah. Yeah, good.
I apologize if that was a lot for everyone. Any questions, thoughts, just things you want to share before we move on to the timeline? Don't have to be shy. Okay. Thanks, Anne.
Thank you, Stacy.
I don't mean to interrupt. With these Medicaid models, are these just for the typical Medicaid, or is this for institutional Medicaid, Katie Beckett Medicaid? I mean, is this including the whole umbrella of it? Because there's certain programs that parents aren't eligible for. So in our situation, we're not eligible for regular Medicaid because I work and I make too much money. So
yeah, we've been thinking about the I think you're talking about the Katie Beckett option. Yes, we are looking at that. Obviously, behavioral health, when it's serious enough and significant, it is a disability, but we do not want to do this in a way where it's a waiver or a wait list. We want this to be a coverage program for any child who is at risk of a serious emotional disorder, who has a serious emotional disorder, or a child that's in the foster care system, all the way up to age 21, unless they're foster care. I think today foster care is 26. So we would, Katie Beckett is an option where you could buy into it, but that is something we're still talking through. We need to work with CMS on how to best do that. But yes.
Right. Because I know that I'm not the only family that is going through this. So,
yes,
I want to be clear if this is something that is available to everyone.
You'd have, yeah, you can do the Katie Beckett option. You can buy into it. Premium.
Thank you.
Mm-hmm. All right, we'll come to questions in a few slides as well. So if anyone has things that are coming up, feel free to share those in the chat or in our next question section. Stacey really set me up well here for that timeline. We're moving quickly in terms of the sheer amount of things we're trying to create and roll out, but we're also moving really intentionally, especially as we think about what that care delivery system modernization and changes will really look like. So you'll see here on this timeline, we have 2024, 25, and 26 laid out. The through line through it all is, of course, this group and every other forum in which we're really working to share our work and get input and feedback. We know that we have a real responsibility to use this moment. I think Robin mentioned earlier, it's a really special time to have this level of focus and resources on this really important work. And we need to do it the right way. And that involves listening to our community, to our families, our youth, and our providers. So this kickoff is a big piece of this, but not only. We'll have a number of other community meetings on more specific topics such as school-based healthcare and how do we figure out the best way to integrate behavioral health screening there. We'll of course have our standard public workshops and hearings for any new policy we're rolling out. And I'll share shortly how we're going to connect with the broader infrastructure. There's so many wonderful forums for children's mental health policy creation and discussion. So really excited to share a little bit about how we're thinking about fitting in with the broader ecosystem. The next 2 years will be really spent on developing those new and enhanced benefits that Stacey's describing. Once we have those within our Medicaid system, we'll then be implementing that delivery system reform. And as Stacey mentioned, that process is all in development, and we're really eager for this group's feedback to make sure we're designing that in the right way, both on the benefits and the delivery system side. So to my earlier point on the working group feedback loop, you'll see here there's many forums that are working here, and there was one that Children's Mental Health Consortium member pointed out to me this morning that was perhaps missing from this list. So we have numerous opportunities for folks to be involved and provide their input on Nevada policy, and I'm really appreciative of the many folks on our representative working group that are also serving in these forums. Our goal, and they may have to be patient with any repetitive information, but our goal is really to ensure that our discussion and our feedback in the working group is being shared throughout those forums as well, to make sure that we're able to be present and answer any questions and also solicit feedback in each and every one of these forums. So I'm thankful to be working very closely with our behavioral health team in Medicaid across a range of folks. And so we are working together to make sure that we're spreading the word and getting feedback in each and every one of these forums. So for this group in particular, just want to do a quick preview of where we're headed. Our next meeting in November, we're really planning to spend some time diving into the data here. What does our Medicaid data look like for this population of youth that we're serving? And Leah, to your earlier point, we want to make sure that that's really inclusive of all the youth that are struggling with behavioral health disabilities and other conditions. So really excited to get feedback on how we're looking at the data and get your input on other ways we should think about this holistically. I'm excited that we'll have we're working on a branding project, which I'll share more of shortly, and so we'll cover that again.
December, we're looking to spend time really discussing what does it mean to build a Medicaid benefit. This is a very wonky world, and we want to kind of demystify some of the language we use and the work that we need to do to share a little bit more about what it means to develop something new for Medicaid to cover. And specifically, we'll use an example of family peer support, something our teams have been working really closely on for the past few months. And so we're excited to get feedback from this group on that new benefit. And we'll continue that in January with another benefit that we're updating and many others in our months to come. So all of this, really looking forward to our path forward together. And I also just want to thank everyone who applied for this working group. We had over 170 applicants for this forum, and each person shared some really thoughtful topics for consideration at future working groups. I've excerpted a couple of them here. Regardless of whether folks were selected for the working group, please know that we're considering these and have them on our list for our meetings moving forward, as each and every one of these is really an important topic and area of focus for our group. So with that, we'd like to open it up for discussion. First with the working group representatives, we'll then move to public comment after that period. We'll only be able to spend about 5 minutes on this discussion, which I know is not long enough, but really welcome any additional feedback on our services and timeline, on the working group structure, or any other background information that would be helpful to you all as we look to begin moving forward with this work.
I just wanted to mention that I used to work in Southern California, and the County of Riverside had a really nice family peer support program, and it was called Parent Partners. And so these are parents who successfully navigated the mental health system for their own child, and then they were hired by the County of Riverside as a job, and their job was to partner with parents and help them navigate through the mental health system as well. And so they were pivotal parts. They would come into my medication management visits with me. We would talk together. If I had a hard time understanding maybe something from a parental perspective, I would pull in the parent partner and we would think it through. They participated in our case consultation meetings. So it was a really nice approach, and they were so helpful. So I would love if we could incorporate something similar.
Thank you, Dr. Cooper. That's great feedback. I'm excited that our behavioral health benefits team is on the line, and I'm sure taking copious notes. And of course, Karen Teacher, Nevada PEP is a wonderful family peer support provider here. So we will be sure to look into that model and reach out to you with any questions. That's great. Alana?
So this is actually like really amazing to see all of this come together. And I wanted to put out there that as working in a CCBHC, seeing this is something that we provide every single day for all of our clients. So the wraparound services, peer support, and a lot of times children, we don't get reimbursed for it. So seeing this is really amazing. And just seeing all the different people that are on this panel, I feel like it's about time that something like this happens. So it's really amazing.
I appreciate the kind words, and I enjoyed a visit out to your CCBHC about a month ago, and really thankful for all you're doing for your community. So a lot for us to learn from. Thank you. And Angie.
Hi, good afternoon. I don't really have any questions about the working group structure. I just wanted to provide some feedback on the services. I thought it was I love the continuum of care and how that's out. And I couldn't agree with it more. I also really like that it's a timeline where we really do work. A timeline that is really going to be here before we know it. And so Stacy, I would just love to say however I can help to contribute towards meeting those timelines. I'm definitely proud to be a part of the group and will help however I can. I love that you're coming into this state and taking this initiative for behavioral health, especially for access for kids, and seeing what some of the challenges are in this state and addressing them and what it looks like on that services model, and with this working group that's coming from different facets to be able to contribute towards it. So I just wanted to let you know some feedback on what I'm seeing. I love it. I think it's great, and very excited to see how we can move this thing forward. So thank you.
Thanks, Angie.
we'll definitely take you up on all that. Any other questions or thoughts? Also, just what can we do to help you guys feel equipped? And as we recognize sometimes we talk a lot of jargon, Medicaid's complicated, and I'll be honest, I'm trying to do better at it. Jargony is like, a problem that we have. So is there something, I want to equip you guys to feel like you can come to the table and engage with us and not feel like you're not understanding what we're doing. So is there something we can do, Brandon? I don't know if that's what you want to tell us. We would love to do that. Brandon, see your hand
I
is up.
just wanted to say, the more I hear you speak about the MCO's involvement, I kind of understand why, my major concern is the more MCOs that we do bring on and how we run the services through them is that one, they are for-profit entities. And then two, they like to do where they subcontract out things, right? So they're bringing in utilization management companies. They're giving contracts to these groups to kind of filter out the providers and manage the network and things of that nature. And what that does is that creates a barrier to treatment and to the access of care. It's because they're giving those contracts to the people that they deem qualified under whatever guidelines that they wish to choose, and what happens is you have some providers let in and some providers not. Then you have some on the client level, some patients are able to get the services they need having that MCO and others aren't, so it kind of, I've seen good things. Like I want to give props to Molina. I've seen them doing some good things lately. But some of the older ones, I've seen them, subcontract out. And now we have all these other entities, SBH, NBH, CareMore, like all these other in between people that are managing the network, and it makes it complicated. And a lot of the providers that I am speaking to in the community, they throw their hands up a lot of times. They don't want to go through all these hurdles, and then they end up not taking Medicaid. We have providers in our state here in Nevada willing to serve, but a lot of times we're not getting them into the networks.
Yeah, no, Brandon, that's exactly the feedback that I want to hear. And I think we all want to hear. So what I want to just tell you guys is like, we want to build this with you. So all of that can be addressed in how we build this. So for example, we can say we want it to be separate, new, specialized one plan or two plans just for this program. And we can make it we can say we'll score higher for nonprofit, or maybe they have to be nonprofit. Maybe we don't do fully risk-based, which, we should have a whole maybe presentation on that about what are the options from an authority perspective, because fully risk-based gets into profit more. When you move away from that, there are other models of managed care that we can do in the state that we haven't done. So that's the kind of stuff that I love that you just said, because like those are things that maybe we say we're going to design to address, right? A model that meets, but it is a big conversation. But I will tell you, whatever we're, like we have to do something different, because what we're doing today, and I think you guys know this, we don't have the capacity. And I don't think even the localities at this time have the capacity to really deliver and create a network statewide that we need for kids, right? And so that's the piece I think and then also the workforce piece is something I just want to acknowledge real quick. And I see Jonathan, your hand's up. But I just want to say from a workforce standpoint, we really, I don't know if you saw our agency requests are out, but we're really wanting to leverage some of our pharmacy rebates to really drive and support training hospitals, clinics who provide training and serve in residency programs to really drive better workforce initiatives. So just throwing that out there, that's another piece of this that's also moving. But we can bring some information to this group about those efforts if that's helpful. Jonathan, I see your hand is up.
Yeah, so historically, legal services has been pretty skeptical of moving away from fee for service for a lot of reasons. I'm excited for this work and what an MCO potentially can bring. But if you have any material that would help us understand the things that are possible, right? Whether that's with nonprofit MCOs or specialized MCOs for, our particular for kids that have these high risk subpopulations, or any things that can be done on accountability for MCOs to make sure that, that last commenter, that those things don't happen. in the build out for this, because I understand there's a lot of stuff that can be put in those contracts, but I don't have a handle on like what is all in the toolbox that we could bring to bear to make sure that an MCO can't kind of wiggle out and put, you know, layers of providers between the people who need care and the care. So any homework reading, I'm happy to do.
Well, Jonathan, I think maybe, Anne, what we should do is get Mercer to help us put together some background information on the options as we dive into that piece of it. And then maybe we more or less, I mean, sometimes I think we like get excited about a model and we forget where we're going with it, right? Like, where's our train driving? So maybe we start with just grounding, like, what are our goals for the delivery system? And then we pick the model that meets those goals, right? And then what are the parameters around that delivery system, Jonathan, that we need to prevent some of the risks and the accountability that we need with that? So let us put our heads together and we will definitely put together a good, you know, maybe it's more than an hour. I know people have a lot going on in their lives too, so I want to be respectful of time, but I think we can put more together for you guys on that topic.
Absolutely. No, thank you, Jonathan, and thank you, Stacy. We are coming up to time here, but this is an important discussion. So Dr. McGreal, I'll turn it over to you for the final comment from our representative group. Then we'll open it up to public comments before we wrap up.
Final comment. Okay. I just wanted to say,
No pressure.
From the provider side of things, I can confirm in terms of like these issues with MCOs. So we provide ABA therapy in addition to, you know, other services. And on the ABA side, it's very highly in demand, but many ABA providers will not mess with the MCOs. It's more administratively burdensome, and you're much more likely to have difficulty with authorization as well as denials of payment that you then have to fight for, which when you're dealing with Medicaid rates, which are already about as subsistence level for many providers, there's just not that extra. So if an ABA provider is contracted with Medicaid at all, they tend to be contracted with fee-for-service, where it's less administratively burdensome to the company to do that. And many will not take MCOs. I'm only personally contracted with select MCOs, even though I'm highly dedicated to serving the Medicaid population for this reason and due to previous issues that I've had with MCOs and just not being paid by MCOs for services that were already rendered. So I think that needs to be worked out. Having, contracts that are on a different kind of model that aren't like having, you know, the risk model, the capitated, you know, contracts where the incentive is to pay out less because, you know, you keep that money is, you know, kind of a big deal. But I also think having other things written in so that there's additional provider support. So you've got added points of contact, because that's kind of the other thing. When things go wrong on the provider side and you're trying to get it worked out, it's oftentimes very, very difficult to track down anyone who even understands the problem, much less can help you work through that. So if we have things written into these contracts that help to mitigate and mediate the administrative burden associated with serving the population, I think that's also very important.
That's very helpful. I appreciate that. And I just want to recognize your experience with that. It's not the way we want it to be, right? So I do think there are things that we are trying to do better in the next contract for our current managed care program on streamlining firehouse and things like that. But we will definitely want to make sure that the goal of this program is that the kids get services, right? And the providers get paid, right? Appropriately. There are moments where that doesn't happen for a variety of reasons, as you know, but when it's appropriate and it's the right eligible, all of those things align, payment should just be automatic. It shouldn't be it shouldn't be a hassle. So thank you for that.
Which is usually the experience with fee for service. So, I mean, that answers a lot of the question why. You'll find more ABA providers that accept fee for service because that tends to be the thing. As long as you check the boxes, as long as you do it the right way, the payment is pretty much
digging in. Yeah, no, that's helpful to know. So yeah, we'll take that back. I do think looking at the different risk-based structures, nonprofit, the different ways to design this in a way, like we're not asking for a health plan to come in and make money off of our kid population. We're asking for a partner to come in and to help us deliver services and have better oversight of what's going on in the marketplace for these kids. So I think if we design the business and the contract to do that, we can get a better result. But part of this conversation is what we're going to be wanting to have with you guys going forward. So thank you. All right, Anne, I know I'm gonna quit talking. We're at 5:01, so.
No worries, no worries. So I'm going to share next steps and then we'll move to public comment. So for working group members, as a reminder, please do submit that availability form. I'll be sharing that over email with you all tomorrow morning. We want to make sure that our November meeting time works for this full group. Please disregard item number 2. We're going to actually revisit our branding discussion in the interest of spending more time and really getting that right. I think today's discussion was an important one to spend more time on. So just one action item, one homework for you. I promise it will take less than 2 minutes. Our November meeting again will, date and time will be pending when you all are available. So we will share that as soon as possible next week. As always, they will be posted to our public notices page. And if you'd like to be added to our listserv, please do include, shoot an email to childrensbh@dhcfp.nv.gov. And with that, we will conclude with our public comment period. So no action may be taken upon a matter raised under the public comment period unless it's already been specifically included on the agenda. This is open to anyone on this call. If you have trouble providing telephonic comment, please do *5 to unmute. Please do state your name and at this time. Thank you. All right. Hearing none, we will conclude for today. Thank you again for the time and for staying 2 minutes over. I'm really looking forward to spending and doing this really important work together. It's really energizing to see all of the folks on this call today. So have a lovely evening and thanks again.
Thank you, guys.
Thank you.
Thank you.